topic is on lung. See, lung. I can say lung cancer is the second most commonly diagnosed cancer worldwide, and cigarette smoking is by far the leading cause for lung cancer, accounting for 80 to 90%. And combustion of tobacco products, multiple non-carcinogens, with most important is polycyclic aromatic hydrocarbon. So this is important that carcinogens. So cigarette smoking, that is the leading cause, and carcinogens are aromatic hydrocarbons, tobacco specific nitrosamine nitrates. So polycyclic aromatic hydrocarbons, tobacco specific nitrosamine nitrates, and additive components of tobacco is additive component is nicotine. So nicotine is not a carcinogen. Nicotine is additive component. Carcinogens are polycyclic aromatic hydrocarbons, tobacco specific nitrosamine, and nitrate. And smokers in United States have approximately 20-fold increased risk of lung cancer compared to never smoker. So how many 20-fold increased risk in lung cancer in smokers? And further, despite the decreased risk of developing lung cancer among individuals who quit smoking, the risk remains elevated compared to never smokers, even after prolonged abstinence. Although cigar smoking is also associated with the development of lung cancer, the risk is lower than cigarette. So for cigar, the risk is lower than cigarette. Why? Because of the difference in smoking frequency and depth of inhalation. So with cigar, there is less depth of inhalation and frequency. That's why intensity is less. Other risk factors include environmental tobacco smoke, secondhand smoking, environmental exposure to asbestos, ionizing radiation, radon, air pollution, and heating, cooking. They are also risk factor for lung cancer. And this environmental tobacco smoke consists of both exhaled smoke and side stream smoke from burning end of cigarette. Risk of lung cancer increased in non-smoker who live with smokers. It has been estimated that approximately 17% lung cancers among never smoker attributed to high levels of environmental tobacco smoke. Several occupational carcinogens, among which asbestos is most common, and it is occurring in mineral consisting of two types, serpentine and amphibolite, seen in construction and insulating materials. Um, Combustion of asbestos exposure in cigarette smoking has a synergistic effect on the risk of, and radon is a radioactive gas produced by uranium decay on soil. So residential radon is the second most common risk factor for the lung cancer, residential radon. So first most common risk factor is smoking, second most common is residential radon, accounting for 10% of the lung cancer. And indoor air pollution from use of unprocessed solid fuels, predominantly coal, wood for heating, cooking, has been associated with an increased risk of lung cancer, mostly from in the developing world. And the presence of familial clustering development of lung cancer in a minority of smokers suggests genetic component is there, and several lung cancer susceptibility loci, and the strongest association is seen with the loci 15q2425, 6p21, and 5p15. Now, systemic manifestation. The systemic approach to the initial evaluation of the patient suspected of having lung cancer should include assessment of the symptoms, signs, and diagnosis, careful determination of the extent. So, for clinical presentation, currently for advanced disease and evaluation is prompted by the onset of symptoms for science, and as lung cancer screening becomes broadly implemented, um, when it is expected that most more patients will be identified in early disease and when they are likely to be asymptomatic. So evaluation of every patient with suspected or known lung cancer starts with a thorough history, physical examination, symptoms, signs will reflect the consequences of the primary tumor, extension into adjacent structure, distant mats, paraneoplastic. So, endobronchial tumor involvement typically presents as cough, dyspnea, hemoptysis, and cough and dyspnea results from direct airway involvement, bronchoria, um, post-obstructive pneumonitis. Dyspnea also reflects disease spread or complications such as pulmonary thromboembolism. Cough and dyspnea are non-specific, and their attribution to comorbidities common in lung cancer patients such as chronic obstructive pulmonary disease may delay diagnosis. Hemoptysis typically is low grade and rarely massive, but less likely to ascribe to benign. So, cough, dyspnea, hemoptysis, localized wheeze, pneumonia, these are endobronchial involvement. Intrathoracic, there will be cough, dyspnea, pleuritic chest pain, hoarseness due to RLN involvement, palsy, unilateral hemidiaphragm elevation, Pankos syndrome, ptosis, meiosis, anhidrosis, shoulder, arm pain, paresthesia, weakness, superior vena cava syndrome, facial and neck swelling, dilated venous patterns on chest, pericardial effusion, weight loss, anorexia, weakness, fatigue, chest pain, palpable supraclavicular lymphadenopathy, unexpected bony pain, neurological features, seizures, confusion, unexplained laboratory abnormalities, anemia, abnormal lung function, liver function, alkaline phosphatase, hypercalcemia, paraneoplastic hypercalcemia, syndrome of inappropriate antidiuretic hormone, Cushing syndrome, Lambert-Eaton syndrome, paraneoplastic encephalitis, unexplained hematological abnormalities, hypercoagulability with venous thromboembolic disease, hypertrophic pulmonary osteoarthropathy, dermatomyositis, and polymyositis. So, intrathoracic spread that we saw already. We look for the